Right, I'll hit record. All right. Thank you for all of those of you who have joined today for our February educational series. We've got Mariah Hess and Jen Anderson presenting today on strategies to enhance your HCAHPS response rates. So Jen and Mariah, whenever you're ready.
Hi. So all of you, I think we've met just about everybody that's on the call here today. I've been with Sparrow since 2011. I've been working in quality and patient experience for about 9.5, almost 10 years. Primarily all my work has been at the critical access hospitals as part of our health system. Currently, I'm the lead quality performance improvement specialist for all of our community hospitals and work in collaboration with Mariah and Tiffany Fryer.
Yes, good afternoon. My name is Mariah Hess, and I am the Chief Nursing Officer at Sparrow Clinton Hospital and Sparrow Carson Hospital. I've been at Clinton for 32 years and in the CNO role for about 2.5, and just joined Carson 2 months ago. So fairly new to Carson. And I have the pleasure of working with Jen on a daily basis too, as helping us through our PI and quality initiatives. And Tiffany had planned on joining us today. However, the Joint Commission surveyors are at Sparrow, Ionia. So she is busy with Joint Commission surveyors this afternoon and is unable to join us. So thank you for joining us this afternoon. I don't think we're going to take the full hour to talk about some strategies in what we do in our health system to enhance our HCAHPS response rates. So hopefully some of this material is a little new to you. So definitely this is our Sparrow pyramid and always our foundation in putting our patients' needs first and our caregivers too, and treating with radical loving care. We are a health system and we work very closely together as a health system. We have we have 5 community hospitals. And we have Sparrow Carson, which is a rural hospital, Sparrow Eaton, Sparrow Ionia, and Sparrow Clinton, which are all critical access hospitals. And then another community hospital inside of our Sparrow Lansing Hospital is Sparrow Specialty Hospital. That is in a hospital within a hospital in one of the towers. And that is a long-term care facility, specialty hospital. So I will go over this part of it here. These are patients that are eligible for our HCAHPS. We know it is a CMS requirement. The eligibility is 18 years and older, at least a one-night stay as an inpatient, 9 non-psychiatric diagnosis, discharged alive, of course, and then patients excluded, of course, are prisoners, patients discharged to hospice care, skilled nursing facilities, long-term care, or has a foreign address. Not sure if everyone is aware that there are some changes regarding the mode of administration for the HCAHPS survey that's going to be taking place in January of 2025, and there are new CMS standards. But right now, the modes of administration for the survey are mail, telephone, mixed, mail with a telephone phone call, follow-up, interactive voice. And some additional modes, like I had mentioned, will be effective January 2025. So you may want to check with your vendor where you could do an email plus a mail, email, web, and phone, or all 3. So I know we have not made a decision yet. Currently, we use our vendor is PRC, which is a professional research consultants. Vendor. In the past, we had used Press Ganey. We switched to PRC. I do believe it was more cost efficient at the time. And we survey 100% of all eligible patients from our inpatient units. And we use the telephone mode in our health system. However, we are joining the University of Michigan. I'm not sure if everyone knows that. And we are now part of their U of M system. And so there are discussions that we will probably be changing and transferring or transitioning to Press Ganey in the future. And a decision has not been made yet on what mode we may be going to when we transfer to Press Ganey. So I will turn it over to Jen to talk about some of the percentiles and response rates.
Thank you, Mariah. So on this website, it's the hcapsonline.org. There's all kinds of resources available about the actual CMS collection of our HCAHPS scores. And one of the resources is the response rate percentiles. So when we look at the discharge time frame for this report, and this is for the April 2023 public reporting, they were discharges from July 2021 through June of 2022, where they based this information. But to be in the 90th percentile, and we're telephone only, we're looking at a 34% response rate. And so I included this here for your information. You need to have at least 50 sampled hospitals in each quarter in order to be included in this metric. So I wanted to share with you, it's kind of a busy screen, but this is all 4 of our hospitals. And what this is, the gray shaded in area are what are considered our inpatient eligible patients that could be receiving a call from our HCAHPS vendor. The green line is actually the score that we received on a scale of 9 to 10, and the 9s and 10s. This is the overall rating. And then the yellow line down below indicates the number of surveys that were collected. And then the percentage above that is the response rate. So it's looking at the number of patients that were eligible, and then all of those responses that we did get. What was our response rate? And you'll see as you look, Sparrow Eaton Hospital down here below has the highest number of patients that are eligible to have the survey, and then you can see the response rates that are down here. And we've all been in that, all of the hospitals in that top percentile on our response rate collection. So I thought this might be helpful for you to see kind of where we are definitely capturing a lot of surveys every quarter. I think we were between like about 45 and maybe 60 surveys on average in a quarter. And I know we've had a lot of conversation about the number of surveys that you need in a year. And so we wanted to bring forward some of this information for you to see in comparison for our hospitals. So some of the key
overall, we're pretty pleased with our response rate. So we are in the top quartile majority of the time, and many of the times we're in the top decile. When you look at the benchmarks for 34% or higher to be in the 90th percentile for response rate. So we're pretty pleased with that. And actually, when you look, a lot of times the higher, sometimes there's a correlation, the higher the percentage rate, sometimes the better your score is as well. You get more of that feedback.
Any questions about this? Okay. All right. So, you know, the last time we were all together in November, we were looking at our HCAHPS scores, and we had the pleasure of having Regina from Clinton come and give her testimonial. You know, a couple of things that she spoke about was just setting the expectations at the hospital and how the overall culture of how we take care of our patients. And as Mariah started our presentation with our whole health system, top of our our pyramid, and top of our area of importance is the patient, the needs of the patient. And then right under that is almost in equal, the caregivers, because the caregivers are the happy caregivers, engaging caregivers are more, we'll see a higher patient satisfaction score. At our hospitals, we have the benefit of sharing some of our physicians, and one of our comments here about provider engagement, we have very active physicians that have goals alongside of our goals on improving their communication with the patients and their families. So we start to see not just our overall quality of care increase with more participation from our providers, and as they increase their communication. And we've had a lot of focus on, at least in our strategy group, regarding the care transitions and how can we improve those scores, utilizing key phrases and involving the patients in their decisions during discharge time, and other additional resources that we have. I still think they're available on the MCRH website, I think.
When Tiffany and Jen and I met this week, and Amanda had asked us to do this open office hours, and we're like, all right, what is our magic to have the response rate? And when we looked at our meeting last week, and 3 of the 5 were Sparrow Critical Access hospitals have already achieving 100 surveys back already for the year. What do we do to get patients to respond and provide that feedback? And some of the key things that we thought of that we think we do on a daily basis is, 1, like Jen just mentioned, is set those expectations. 2 is collaboration. And that collaboration is throughout the whole entire organization. That's from the frontline staff all the way up to the president of the hospital, even to our board members. Having that collaboration and that buy-in from everyone is key. And why I talk about that is our president of our facilities, they round on patients. They round on the patients with the managers. And so I will see the president rounding with the inpatient manager, going into rooms, talking to them. And part of our scripting and part of our conversation during the rounding is, we love to have feedback. You will be receiving, you may be receiving a survey. Please take the time. We appreciate the feedback. We look, and we develop actions based on that feedback, and we encourage people to complete those surveys. As Jen mentioned, the provider engagement. Right now, we have a consultant hospitalist group that we use at all of our community hospitals. And the next slide will give you an example of some of the things that they're doing with the provider engagement. And then the other thing is all of our leaders, we have that leader standard daily work with visual huddle boards, the white communication boards, the communication with staff, and encouraging, and then also they're rounding with patients and encouraging that feedback and for patients to complete surveys. Regarding provider engagement, we have, it is a little easier. We have this contracted consultants throughout our whole health system. We use Vituity, and they provide all of our hospitalist services. They have rolled out this team approach, and they hold their providers accountable for their goals. We actually have a hospitalist scorecard, a dashboard, and it is presented at every medical executive committee meeting on a monthly basis. They present their scorecard. We have quarterly touch base meetings with our president, the CNO, the ED managers, the inpatient managers, and the hospitalist medical directors, and our ED medical directors. We all meet on a quarterly basis. We talk about any concerns, any issues. We talk about quality metrics. We talk about, they present their quality scorecard. Of course, I work with them frequently because I'm at every MEC, and we talk about the scorecards together. They present at performance improvement. But one thing that they rolled out is this human connection with patients. And they rolled this out a few months ago, probably about 6-7 months ago now, maybe even longer. And it was part of their initiatives and tactics to go along with to improve physician communication on HCAHPS, and then also some of their other additional goals that they have on their quality scorecard, like length of stay index, readmissions, communication. But they have these cards that they hand out to patients, and it says, our care is your care is our mission. And so, and it talks, and they put their doctor's name on it. And then on the back of this card, and I didn't show the back side, there is a area for them to write down questions as well. So patients could write down questions for the next day for their rounding. But then they talk about in each of these, this human connection with patients that's on the left, it's a badge buddy. So the physicians can keep this right on their badge, on their ID badges. It's just a little badge buddy. And it talks about and reminds them, they need to hear the full story. They, heed the worries, help me navigate, be honest with me, heal me, my understanding, and leave me with hope. And then these are some key metrics and phrases. And when we talk about response rates versus working towards some of the metrics or domains of HCAHPS, I think they go hand in hand, because when you have these initiatives, the scripting, the collaboration, and everyone's on board and encouraging patients to provide feedback or to complete surveys, that all goes hand in hand and correlates together. But having that connection with our physicians is key. Now, Vituity also staffs our emergency departments. They have ED providers as well for Ionia and Eaton. However, Carson and Clinton, we still have our hospital employed ED providers. So sometimes we do have that little bit of disconnect when they roll something out for Vituity and have expectations and that accountability and goals for their Vituity physicians. We have to somewhat mimic or ensure that we have a lot of goals that correlate with our employed physicians as well, including also our employed surgeons. So that is still a work in progress. Jen, did you want to add anything to that?
Yeah, they, as part of our overall quality assessment and performance improvement plan, and engaging the physicians with our overall quality and experience, they are actively, as Mariah said, meeting with us. They initiate some of those meetings. They participate in we have some regional hospital projects that we're working on, such as early identification of sepsis. We're looking through readmissions, and they are actively involved in helping us be the physician sponsors on those projects, letting us know, or working collaboratively with us. And it's been, I think we are very blessed right now with this team of physician leaders that we have, that, like, for example, the medical director of the emergency department is also the chief of staff at Sparrow Ionia, very actively involved in providing patient care and leading his team. And then collaborating with his colleague who is in the inpatient unit, and the communication, the handoff between physicians, then just makes it a better overall experience for the patient. We have patient family advisors, and they give input to us on how patients are experiencing their time, their family are involved in their care. You know, a lot of times, I'm sure you all had this as well during the COVID pandemic, when we had all those restrictions on visitors at our critical access hospitals. We were adhering to the necessary protocol, but we were also able to be a little more flexible in making sure that families could connect to the patients, whether it was through a Zoom meeting or making phones available. We were doing all kinds of things to make sure that the family stayed connected. Another thing I just wanted to add was Mariah was mentioning about the nurse leaders. There's an expectation that the nurse leaders, the managers in the departments, visit each of the patients and their families when they're here during their stay. And boy, they just really get to they really get to know. I'm sure it's the same in your hospitals, where the nurse leaders really get to know the patients and their families, because they see them every day for 2 or 3, 4 days. So I can't really emphasize enough that collaboration between the physicians and the team. It makes a big difference in the patient's perception of their care.
And I think there's a question in the chat on how do you get providers engaged or on board? I think, you know, we're always going to have those few that we struggle with or that are a little more challenging. But overall, when we continuously talk about the connection and the reason and the why, you know, usually we will get them on board and we hold people accountable. Another thing is visual awareness. I mean, we have communication boards. They are public facing. Many of our communication boards are public facing, and physicians want to be connected and they want to be involved because, I mean, many of them live in our community. They live in our community. They go to church in our community. They're part of our community. They take care of your neighbors. They're taking care of their friends, their family members. And, you know, we want the best for our patients, and they want to be connected in, you know, a reflection of them as well, of positive response rates and engagement, and they want to make sure. And plus, you want a good response rate, a good N number, so it can be statistically sound, and then they also reflect and take pride in that. Like, yeah, you know, we've recently went to point of care surveys for our patient loyalty surveys in our emergency departments. And let me tell you, so they're averaging anywheres from 90 a month to 400 a month surveys in our EDs. And it is it's remarkable when I'm in the physician committee meetings like ED or medical executive committee. The physicians are all saying, wow, you know, 300 responses. Now that's statistically sound, you know, that's a statistical number for me to get behind. Like, okay, these are our successes, and this may be an opportunity for improvement. So I think when you have that continual awareness, you talk about it, you communicate about it, I think then we get physicians on board. Also, some of the physicians, it is in their contracts. It is goals. They have goals set as part of their scorecards or initiatives. And sometimes there are incentives attached to it as well. So yeah, don't always think it's not just, you know, there are incentives too and goals that they have. If they meet these goals, you know, there are incentives as well. It's not so much incentives on response rates as it is the outcomes.
And they're super competitive. That's the other thing that we've discovered through this process, is that they if they're looking at we're doing a little more comparison across our hospitals so they can see how they are ranking to their peers from Eaton to Ionia to Clinton to Carson. And they're really competitive, and they want to have the highest scores.
Yep. And plus you can drill down by providers, and we share those graphs as well. And so definitely, out of 15 providers, and if you're down below, as Jen says, that doesn't feel good. So they do need to at times, step it up. And then our leader standard daily work, I'm sorry, I had skipped that a little bit on that slide. That was slide 9. It goes back to what I said, the rounding, the scripting, the communication, and the huddles. And that is expected of all leaders. Another thing that we had talked about before last year at one of our MICA meetings is our nurse leader rounding tool. And it's the little iPad that the nurse leaders can use when they go in round, and they can definitely track and keep, and then we get a weekly report, and then we get a monthly report. And that has been very helpful as well. I think that helps trigger some reminders and scripting to, hey, once you're discharged, you will be receiving a survey. We really appreciate you taking the time. But the nurse leader rounding tool also helps us, I think, provide some additional support for our outcomes too on our HCAHPS. It's a automation and accessibility for rounding tools. It optimizes our rounding workflow. It's standardization for rounding. And then it captures a lot of data, identifies any trends, informing unit level important initiatives. Like we have a whole section on there regarding the fall bundle, and then also one on medication education. And then it also holds, one, the leader accountable for rounding, because we can see those reports, but 2, also for staff to ensure that they are following processes and protocols. And then also there's an opportunity to give kudos and engage bedside nurses on a lot of the things that they do well. So that's a great tool that we have been using here at Clinton for quite a few months now.
Mariah, something else that we have implemented at our hospitals is, along with the DAISY Award, a B Award, Be Excellent Every Day. And this is a complement to the DAISY Award, recognizing that non-clinical caregivers or some of the ancillary staff caregivers are necessary for nursing to be able to take care of patients. And the engagement and the collaboration with that team and just the recognition helps build the expectations for excellence across all parts of our organization, which then just helps improve and enhance the patient experience. What questions do you guys have for us?
Yeah, and we did include some tactics to support the survey. Training all staff to respond to call lights to the best of their ability, hourly rounding, our keywords, communication whiteboards, training all staff to notice and patient pain, teach back, discharge phone calls. And then, as Jen had mentioned earlier, involving families. We do tend to see a geriatric population. And I think when we involve families, I think families will help, or reminders to help with the survey as well, if need be. I think that's also a key too, because when you hear your family, if they're satisfied with their care or they had a good experience, then usually that's more positive too for the patient as well. Yeah, but we're open to questions, ideas. I don't think there's a magic lamp that we get these responses. I think it's a little bit of everything, but I think the key is rounding and collaborating.
And has anybody had, let's look at all the generational gaps that we have in our workforce. And then, as Mariah said, the elderly population, and then the experienced population, and then the younger folks that are coming in, the younger generation that's coming in caring for them, big gaps, right? Just wondering if there's been anything that you've learned from your organizations, um, engaging or connecting those generations.
Jen, do you mean
Well,
connecting, I'm sorry, do you mean connecting them to the surveys or making a connection between the ages or the gap in ages of the patients?
So good question, Amanda. So in our rural communities, we know that not everybody has access to broadband. They often have cell phones, and if they do have a cell phone that's a pay-as-you-go kind of phone, receiving a call from a number that you're not familiar with, they may or may not answer it because they're limited on their minutes. So that would be one component, and then the other component would be absolutely the communication. So often like my kids, just as an example, my kids, they're all about their technology. Everything they do is in their technology. And then when dad says, okay, let's get your tax stuff around, you got to print this and and he's so old school. He's not that old, but he's that old school about we got to print it. You need to sign this versus electronic signature. I mean, it's a whole different way of managing life because they are the younger population is so connected to their technology. I was just curious what other people's experiences have been.
Jen, in your tracking at the facilities, are you able to look at the responses by age range? Are you able to see where maybe there could be improvement with communication to say maybe the younger generation, since maybe, they might throw a piece of mail away or not look at it and find it important to return, or answer the phone and participate with a survey? Can you tell with your tracking where improvements could be made based on age range?
I would say the majority of the surveys, it could be more like like your point about the response rate. The age of the population that is responding, I don't know if I have that stratified in that way to know like what percentage of our population, majority of our population is this older population, right? We do have younger people, but not as much as we have the older population. So I don't know that, I don't know if I have it stratified in a way, looking at the ages saying, are the 18-year-olds or the 25-year-olds not responding to survey? I don't know that.
It would be interesting to keep track of that as we transition into alternative ways of answering those surveys as we move to 2025. Would just be interesting to see if there's an increase or decrease in response rates. But I see Barb has her hand raised, and so does Heather.
Yeah, I'll just comment personally, right? Because I've started to help care for my elderly patients. And of course, I'm my elderly age and I have younger kids. And with these surveys, it's gone to our phone because we now can do it that way. And I was with my mom who has Alzheimer's, right? And we're trying to run through her survey. What amazed me was how long it was. Like I was so over it time I got done because it just went on forever. And I'm sure some of it was questions for CMS, and some of it was about our organization wanting to know stuff. But I'll tell you once, I'm not going to do it twice. And
Hey,
I was helping her. And
that's
then,
right.
I see other
No, it's
surveys from
not a
visits
big deal.
coming
My
to me,
SMG office just reached out to me.
and it's the same thing. It's just like, I think it's too complicated for people. Like it's got to be shorter. And maybe, we want too much for what I think we're asking them to do. And so I find myself knowing that I should answer all fives and everything for everybody, right? Because I know better going, not going to do it, right? Because it was just a pain in the butt. and I wonder what other people think too. And my mom could have never, and my dad together a million years, gone through the phone and done it. So I don't know. I think there is a generational thing and where we're moving, and how do you capture that older population to respond back? Because we're not getting it another way. We're either getting it through my chart, which is our electronic record, or we're getting it on our phones, right? And it's kind of complicated, I think. So that's just my thoughts.
Barb, this is Heather. I would echo that. I haven't had a survey for myself in a while, but I just had a survey on behalf of my son. And I will tell you, I got it paper in the mail and I got it on my phone via a link. And I think I got an email. And we actually, because I live almost an hour away from where I work, it's a different system. So, I mean, and I did fill it out. I ended up filling it out paper because I do feel like there are certain things. I feel like I also met that generation where some things I prefer paper, some things I prefer electronic. So I did fill it out paper. But I will also say that if somebody called me on the phone, I would probably 100% not answer and not call them back. I hate to say that, but like life is just too busy right now. So if anybody tries to call me at work, there's just absolutely no chance I will take a survey call like that. And at home, it's too busy with family and activities and all of the things. Like, absolutely not. Maybe different generations think differently, but for me, like, so I'm with you though, Barb, because I was answering it on behalf of my 15-year-old son. And the basic questions, yeah, no problem. Because I really wanted this provider to get the praise I felt she deserved. But all the demographics and all of these things, like, you already have this information. I'm already in your system. My son's in your system. Why the heck are you asking again for it?
Yeah. Yeah.
So that was that. But I did want to, gosh, now I'm like practically forgetting why I even raised my hand, because you did ask a question. Oh, about the generations. I feel like our hospital is very similar to yours. With Sparrow, Ionia, Clinton, and whatnot. But I actually, if things are handwritten or whatnot, oftentimes, we'll get some of those sent back to us, or patients will not use the envelope provided and send it back to Preskini. They'll just put it in an envelope and send it right back to me at the hospital because my name's on the cover letter. And I get those probably once or twice a week.
Yeah.
And one gentleman, he was quite tech savvy because he had snipped a picture of his survey and inserted it into his letter that he typed to me and told me how upset he was with how delayed his survey was, how his survey should be coming to him immediately after he leaves the hospital. He was there for outpatient service. How by the time he got it in the mail, it was too late. He couldn't remember, all of the things that were going on. And he basically lit into me about how delayed it was. And he was an elderly member of our community. So I like to use that kind of like, oh, let's give them the benefit of the doubt, but they're becoming more and more savvy. Like, I use my mom as an example. She just got a smart TV and switched from traditional cable to all of the apps, and she's probably better at it than I am. So I got my butt handed to me because, heaven forbid you give the provider a day or two to sign off and chart and get it coded and whatnot. And
you kind of bring up a good point, Heather, the extremes, right? It's either
right.
I'm really happy and I want to give that provider the best feedback because they really deserve it, or you've got complete complaints. And so then when you get all the people who didn't answer and you have these two extremes, and you get these scores that are like, wow.
Yes. We live in a society of immediate gratification, entitlement, and it's now seeping into the seasoned generations.
The seasoned, yes. Mariah, just so you know, I'm going to have to jump off the call because the next session and Joint Commission is going to be starting here in a few minutes, and I am presenting there. So I am going to need to hop off for that. So thank you all for your time today and hearing our story.
Good luck, Jen.
Yes,
Good luck.
yes, good luck. We do appreciate everyone jumping on, and you know, we used to have signage and stuff posted, you know, you'll be getting a survey, but you know what? We haven't had signage in years, and our
Mhm.
response rate, you know, it still remains high. I think the big thing is that face-to-face when you're rounding and scripting that, encouraging the survey response. I think that really is part of the key, and then collaboration, that we're all on board and all on the same page. Like I said, it's no magic lamp. So, but anyone else have any questions or thoughts or ideas? I appreciate everyone taking the time this afternoon. Oh, Julia, that is sad.
Yeah. We do more observations more than we do inpatients. So we have a really good response rate. We get about 50% of our inpatients return surveys, which I believe is a good response rate. But it's just we don't have that volume anymore. So it's hard. We've had 5-star ratings for several years, and this is our first year we won't have one.
About how many survey responses did you get back, Julia? Are you close?
We're at 57 at the end of Q3, so we're not even close enough to. We know we're not getting it. But the observation piece really comes down to our joints. For a long time, we're seeing as inpatients, joints are not doing that anymore. It's more of a utilization review piece. There's more insurances now that we are starting our patients as observation when they're coming from ED. And so most of our patients automatically are observation rather than inpatient. It's a different world now, but there's a lot of pieces related to insurance there.
There is a lot of changes with insurance.
Yeah.
I know, looking at you know, do you have others trained for off hours and weekends regarding interqual criteria to ensure that you are placing them in the appropriate setting and getting that inpatient status versus observation when it does meet the criteria? That is very important.
Yep, absolutely.
And I'll just be pie in the sky. So, I mean, I recognize too, like we're doing some more observation, what puts us at risk too. And I think the important part is those that do respond, you take a look at what they have and how they appreciate you, and share that good news too. You're not getting the 5-star rating, but you know what you're doing is worthwhile. And that's important too.
Yeah.
That it is. Celebrate all the wins when we can.
Yep, you bet. Because they're getting good care.
And you hear it time and time again. Yep. You know, you're not treated like a number. You're part of the family. Those are all wonderful things. And that's what I think every single one of us on this call, we can take a lot of pride in our critical access hospitals for that type of care. And I think that's I know that is the reason why I still work in a critical access hospital, is that culture and that family touch that you don't get everywhere.
You know, Mariah, we just did that huge survey, all of us, and I can't remember how nationally it goes to what, but they're looking at indicators for critical access hospitals. But that is why I think it'd be great if they did, because maybe they could create a system for this observation, for this, the tweeners are where we're between, so you can still get recognized. I don't know if that day will ever come for critical access hospitals, because we do deliver great care. We're out there by ourselves. We multitask, and it's hard to get that recognition awards when you're in these bigger systems or bigger, like, they have numbers. I know numbers count, like, don't get me wrong, but it would be nice to create some kind of system that kind of level sets, and any input that obviously I don't know if you were Jen on that group, but giving that input to create that across the nation would be lovely, to recognize us, right?
Oh, good feedback, that's for sure. Does anyone else have anything that they'd like to share? Or maybe you guys also have a great action or intervention or tactic that you have to get good response rates? Julia, you got a 50% response rate. That's amazing. What is your key? Yeah, sure.
I really don't have a key. We have tried some leadership rounding at the bedside. We haven't actually done that as frequent as we used to because we had some change in leadership. So that has changed, but our response rate didn't. So I don't know truly how much that really influenced our response rate. So that I think that's interesting. We used to also with discharge give them kind of some scripting to say to please like give us your feedback, and that's also something that has kind of fell off the bandwagon a little bit with staffing changes. So but our response rate is still doing okay, so we're just hanging strong. We might be able to get more response if we get our staff back on track again. But we still probably wouldn't make our star rating because,
Of the volume.
yeah. So, but I don't have a secret weapon right now.
Yep. Same as here is everything that we said. Yeah.
Yeah.
Rounding, scripting.
Yep.
And collaboration. I think, yeah. And it's not the rocket science. It's a lot of the basics, a lot of the things that we do on a daily basis.
Yep.
Well, thank you for the opportunity, as Jen said, to hear a little bit of what we do within our system and working towards it. But it'll be interesting to see and consistency. Heather, you're right. Consistency is key as well. But it would also be interesting when we look at our surveys that we just recently took, what vendors everyone uses as well. We've heard Press Ganey, we've heard PRC. We're going to probably be switching to Press Ganey, back to Press Ganey again with joining U of M. But the cost is, it's costly too. It's not cheap, each survey. And so I don't know, what the changes coming out in January, what that cost is going to look like, depending on what mode of delivery you choose. But people want quick and easy.
They do.
They want quick and easy.
All right. Are there any other questions this afternoon? And if not, we can get back a few moments of our time and just give everyone more opportunity. Tammy, I saw you come off of mute. Did you have?
No questions.
Okay.
I did actually pick up a couple of pointers though from the meeting that on nurse leader rounding that we were talking about instituting here. So it was very helpful to us.
Great. I'm glad you enjoyed. All right. Well, I want to thank you, Mariah and Jen and Tiffany, for putting together this great learning experience for us today. And everybody enjoy the rest of their Thursday afternoon and have a fantastic weekend.
Thank you.
Thank you.
Thanks. Bye.